Hi YouTube, thank you for clicking on my channel, Leonora Loves Nursing, and in today's video I want to talk about bedside report and what things that I look for when I am getting a report from the offgoing nurse. If you guys are interested, stay tuned. I have my laptop in front of me and I have some notes here, so if you guys see me looking down, I'm not trying to be disrespectful. I am looking at some notes on the computer or my notepad. So report is extremely important. If you're a student or if you are a nurse, it is extremely important that you ask the right questions. Depending on the questions that you ask, generally gives you a broad overlook of the patient. So some of the questions that I ask for in bedside report, of course, is a patient diagnosis. But before I even go through all that, I come to work at least 15 minutes early just so that I can sit down on the computer, look at all my patients' labs, look at any pending orders, just to get an overview of it. And then once I'm done, once it's time for me to clock in, then I either look for the offgoing nurse, or the offgoing nurse finds me because they're super excited to leave after 12 and a half hours, right? I look for the nurse to give me a report, and these are the things that I look for. Now, I want to make sure that I get a great overview of the patient. So I look for, aside from the patient, the age, the sex, when they're admitted, their diagnosis, I definitely look for history. I want to know the comorbid condition / history of the patient. I like to find out what we have in the system and also what the offgoing nurse has, if they have any further information that the patient has told them from the previous shift. And I also ask myself if there are any history that has not been recorded on the computer, especially if it's a new patient. I want to know if there's any procedures that the patient is going for that day. Any planned procedures so that I can plan my day correctly. Any allergies. Now, allergies should be on the EMR, but sometimes you never know if there could be an allergy that the patient did not report during admission. So I want to make sure that the allergies that are on the EMR is also the same allergies that the patient is telling me as well, so that we're not missing anything. Last thing I want is my patient to have an allergic reaction. So I also want to know code status. I want to make sure, this should be in the computer, but I want to make sure that the patient didn't change from a full code to a DNR from the previous shift, or it's not thinking about it. I work on a medical, surgical, and an intensive rehabilitation floor. So one of the main things, if I'm not on the medical, surgical floor and I'm on the rehabilitation, physical rehabilitation side, I want to know how the patient ambulates. I want to know if they're a min assist, if they're a moderate assist, if they're a maximum, which is also total assist. So I know that once I enter that patient's room, I know that I'm going to need either 2 or 3 people to help me lift this patient up or get this patient in and out of bed. I want to know also, this is really for the rehabilitation side, if the patient is continent to bowel and bladder. I want to know, should I be changing the patient every 2 hours and as needed? I need to know those things so that the patient is not sitting in any bodily fluids. I want to know that what VTE or DVT, deep vein thrombosis prophylaxis, that the patient is on. This is mandatory on my floor, that especially on the rehabilitation side, that all patients must be on a sort of DVT prophylaxis, either if it's Lovenox, Coumadin, SCDs, or TED host stocking. The patient needs to be on something, because usually on the physical rehabilitation side, the patient is not ambulating as much as they should, especially when they're new. So we need to make sure that we're doing everything that we can to prevent the patient from getting a blood clot. So that's very important, very important. And if the patient has any IV access, I need to know also if the patient is on any protocols, either magnesium or potassium protocols. Usually on my floor, those are the 2 main protocols that the nurses must check for. So if the patient is on a potassium protocol, the first thing that you have to do is check the patient's potassium level. Now, we do not Worry about if the patient is on a magnesium or potassium protocol if those labs have not been drawn. The labs needs to be drawn that morning. Then based on the number, we are going to replace any electrolytes if needed. So if the patient's magnesium is 3.0, there's a protocol that the nurse must follow. If the magnesium is 1.3, 1.2, there is a protocol that the nurse must follow, and it is the nurse's responsibility. It is not the physician's responsibility, because he or she has already put that protocol in the system. If the doctor comes and sees that the patient's magnesium, the electrolytes have not been replaced, you can definitely get in trouble. It is your responsibility to check yourself and also ask the off-going nurse if the patient is on any magnesium or potassium protocol. And also, if the patient is on any type of protocols, you want to know if that patient has been, what were the labs yesterday, or how many milli equivalents did you give of potassium yesterday, just so you can get a generalized idea. Also, I asked the plan of care. Usually nurses, they're so eager to leave and they're so tired. Believe me, I'm exhausted at the end of 12-13 hours, that they're just giving you a report and they're not really telling you the plan of care. You want to know what is the plan of care of the patient, what's the patient's status, what are we waiting for, and things like that, so that you have a generalized idea. Then you get into, of course, you take this information with a grain of salt, because not all nurses do a thorough head-to-toe assessment. They listen to other nurses and other nurses and other nurses. So once you ask the patient, once you ask the off-going nurse about the report on the body systems like neuro, cardio, GI, GU, integumentary, you just take this with a grain of salt, because you're going to do your full head-to-toe assessment. So of course, we know the patient's Layer North times 3, generalized cardiac, like any edema to the bilateral or generalized edema. You want to know if the patient has any Foleys, if the patient has any dressings, any skin tears, any dressings that were done on the previous shift, respiratory, are they on breathing treatment, are they on oxygen, any specimens that need to be collected. But that is why you need to, before you get a report, you need to check the computer to see what the nurse has done and what the nurse has not done. There are so many times where nurses, they think they're slick and they were supposed to do something on the previous shift, and either they didn't feel like it or they didn't use their time wisely, that they're going to try to dump that load on you. No, not with Leonora. You have to give me literally a good reason why you couldn't collect a urine specimen, especially if the patient has a Foley catheter. That's like, you know what I mean? That's so easy to, obtain a stool specimen, or unless the patient obviously didn't have a bowel movement. But, if the PCT is telling me, that the patient had 3 bowel movements, why didn't you collect the stool specimen? Why didn't you collect the urine specimen? Why didn't you collect the sputum specimen? You have to be proactive, and you really have to be really, not strict, but you have to be really stern about certain things, like dressing changes. There are certain dressing changes that are usually done at night, and certain dressing changes that are usually done in the morning. If there was a dressing change that you did not do, why didn't you do it? You have to really give me a legitimate reason. Maybe I'll take it one day, you didn't have time, but if every time I'm getting report from you and the same nurse, and you're not doing what you have to do during your 12 hours, that's when we're gonna have issues. And definitely speak to the nurse. If not, go to the charge nurse, go to your nurse manager, because that's not fair to you at all to be doing 7 p to 7 a work when you have your own work to do. So I know this is kind of all over the place, but I hope you guys have a generalized understanding of how important bedside report is. Also, do not get report without checking do not receive report without doing bedside checks together. Sometimes, God forbid, you know, some nurses are really lazy. Sometimes you'll get report and that patient is dead in the bed, and they know they're dead, but they don't want to fill out the paperwork. They don't want to do all that stuff. Now, guess whose responsibility it is? It's your responsibility. Make sure your patient is breathing. Make sure that all their concerns from the previous shifts were answered. And that's how you kind of help with time management on your shift. So, guys, if you have any questions, comment down below or send me a YouTube inbox or email me leonorelovesnursing@gmail.com. I respond to all comments. I respond to all emails. And if there are any other nurses out there, hi, leave me a comment about what you what are certain things that you really look for in bedside reporting. Now, like I said, I'm a medical surgical nurse. I am not an ER nurse. I am not an ICU nurse. So my reports are going to be definitely different. But I hope you guys like this video. Thumbs up and subscribe, and I will speak to you guys in my next video. Bye.